मेल कराओ मेल।
क्या है ब्लड? नहीं ब्लड के साथ लगाओ, एक ब्लड के साथ डायलिसिस करो।
अभी इसका लिंक भेज दो तो मैं आगे भेज दूँ।
बिना ब्लड के नहीं।
ये तो लाइव में देख के आ जाएगा।
आ जाएंगे।
वो चैनल तो उनको पता ही है।
कोई आ ही नहीं रहा, कोई फायदा नहीं हो रहा।
अभी थोड़ा टाइम लगेगा इनको लाइव नोटिफिकेशन जाने में, कुछ सेकंड लेट होता है। अभी जैसे इनको नोटिफिकेशन आएगा फिर और
एक ही मिनट लगेगा, मतलब ज्यादा तो लेट नहीं।
हाँ, दिक्कत कर रहा है उसमें। ये तो नेट कनेक्शन अच्छा।
एक लोग हैं कोई साथ में, उसे आप ही से डिस्कस कर लेते हैं, आपसे बहुत सारी बातें करनी है। MN Medico Point, good afternoon. Hi, good afternoon. Can you write your name, MN Medico Point, and from where you are speaking to? So we could not connect you. You can just write your queries, your questions, and whatever doubt you are having, and you can briefly introduce yourself in comment box. So first of all, I would like to introduce you all with my team. Hi, good afternoon, Furkan. How are you, Furkan? All right. So should we start? Because we have only
the introduction.
Yeah, sure. All right. So we have my team with us. I myself, Sheikh Saadi, in the clinical department as therapeutic analyst. With me is Dr. Yasir. He's a clinical manager in the Department of Clinical Excellence. Dr. Yasir.
Hi everyone, I am Dr. Yasir. I am as a clinical manager in clinical team. Okay, so nice to meet you all. Let's have a good session. Okay.
All right. So we have met Dr. Yasir. Now it is time to meet one of our oldest employees with us. Mr. Deepak Sharma is with us. He's clinical regional manager looking after Delhi NCR clinical operations. So hi Deepak, how are you?
Hello everyone. I am Deepak Sharma. As Sheikh Saadi sir has mentioned, I am the oldest employee of DCDC Kidney Care. I am working here as a clinical regional manager looking after Delhi NCR for clinical operations. Thank you so much for joining with us. Let's have a good session. Let's talk and let's have an interactive session. Thank you so much.
Right. So as he mentions, let's have a interactive session, and please be open with your questions and queries, even if it is a very basic question. If you don't feel hesitated, it is the learning platform. You need to be zero when you are learning. So try to ask more and more questions, more and more doubts. Anything which is concerning you, which is giving you tension, release out your tension about dialysis, about therapeutic dialysis, about clinical dialysis, whatever doubt you are having, just go and ask in the comment box. So lastly, I would like to introduce with one of my colleagues, Mr. Sanjay. Mr. Sanjay is looking after the clinical operations of UP West region. He is also the clinical regional manager. So hi Sanjay. Is Sanjay with us?
Hello friends, very good afternoon to everyone. So we will discuss today about adequacy of dialysis. We will brief the topic here, and if you guys have any doubts or question and queries, you can put in the comment box. We will try to answer all of your question and queries. Thank you very much.
All right, that's very nice of you all guys. Thank you for joining us. And let us reveal what is the topic of today's discussion. So we are going to discuss about the hemodialysis adequacy. So hemodialysis adequacy is one of the important factor that is determining how good dialysis or how adequate dialysis you are giving to the patient. We will go through each and every part, each and every section of the uh, adequate dialysis. We'll discuss some numericals. We'll discuss the pros and cons, techniques, tips, and tricks, of course. How can we improve our skills? How can we a distinguished dialysis technician? So these would be there would be a part of in the dialysis adequacy we have two aspects: the technical aspects and the clinical aspects. So we have our whole clinical team with us. We have the clinical specialty, clinical expert, Dr. Yasser with us. We have the technical team also as well with us, Mr. Deepak Sharma, Mr. Sanjay Chaudhary, me. We will be guiding you throughout the session about the adequacy of dialysis. I would like to have more and more questions from your side so that this session would be more interactive. We will be taking each and every questions from your side. So please be ready. Let us start the session. So anyone who can answer what he or she understands with the term dialysis adequacy? Anyone can answer in the comment box. मुझे नहीं दिख रहा ना लाइव चैट ठीक है. Hi, so good afternoon to all who have joined with us. So I was talking about the adequacy. So adequacy of hemodialysis suggests and tells how good dialysis a patient is taking. It is basically the dose of the dialysis, like the amount of dialysis should be given to a patient. That can be helpful in determining, in correcting the symptoms of uremia. So on the specific look of uremia, the symptoms of uremia, we have Dr. Yasser with us, who will be telling you about what is uremia, how it presents in the form of symptoms in dialysis patients, what is the lab investigation that need to be prescribed when patients having uremia, what other conditions are associated with the patients of uremia, and why uremia is important in the dialysis patient, and how it will be linking with the hemodialysis adequacy. So I'll be requesting Dr. Yasser to join with me and to guide you all about the uremia and what is uremia. Sir.
Hi everyone. Like you all know, when the patient is come on dialysis, he having a high amount of urea and creatinine. That is creating a problem in the patients. So, what can be a symptoms like patient is having when he's having uremia? So, what is uremia? Like high levels of urea and creatinine, and that functions are making a problem for the patient because the patient is not started his dialysis. So, what are the common symptoms what patient is having at the time of uremia? Are like the patient not able to eat properly. He is having vomiting always, like nausea. He has a feeling of vomiting always. He don't want to eat anything. He's having like uneasiness in the body, like he is not feeling well. He don't know the reason. What is the main reason of that thing? So day by day he feel very weak, tired. He always have vomiting. So due to that the patients lose their weight, and we don't know the reason why the patient is losing his weight, but the main cause is uremia. So as soon as we start the dialysis of the patient, when he come to the CKD stage 5, so those symptoms get to the patient feel better. So now we don't feel, now usually we don't see those features in the patient when he start on the dialysis. So now the term comes that adequacy of dialysis, like how good dialysis you are giving to the patient So we must have, like, we just like whenever we say, yeah, patient ask us like, doctor, I'm not getting a good dialysis. So you always say, you always reply, no, we are doing very good dialysis. So we can't say just like that we are doing a good dialysis. There should be a some formula or something, like you can show clinically to the patient that we are doing a good dialysis. So in this session we are going to discuss those things, like with the help of those things we can determine that we are doing a good dialysis. So first of all, you always know, like we can check a urea creatinine levels of the patient. As soon as we start the dialysis for the new patients, the levels will be high, and as soon as we start the dialysis, the level will be decreased. So there are so many different features of uremia. Maybe all of the patient will not have all the functions, all the features, but yeah, there are some common features. So common feature, common symptoms of the uremia. So one of the feature is encephalopathy also. Like the patient will have altered sensorium. He will not reply to you, he don't talk to you. So many times we see, like the patient is coming for first time to the dialysis, and the response of the patient is not that good. So sometimes we are, as a technician, we are afraid say that we will do dialysis for this patient in a standalone center or not. Maybe that patient need a dialysis in ICU unit. So these are uh, not very common features, but yeah, there are, these are the feature that all, like, dialysis patient will have in some time of their life. So as soon as we start the dialysis, these symptoms will improve and patient will feel better, and their health, that clinically they will feel better. So how can we say that we are doing a good dialysis? Is always like urea and creatinine levels, mainly the urea level. So if the patient asks us, doctor, my dialysis is not good, I'm not having a relief in my symptoms. So we say, okay, let's have a sitting with you and we talk about this. So we talk about we see the reports of the KFT, and we see the levels of urea creatinine, what the patient was having at the time of starting of the dialysis, and now what are the levels. So we can show the patient, see, your urea was that time 200, and now your report is coming, the urea is 100. So from that time your urea is now reducing. Your creatine levels that time was around 16, but now in your reports the urea levels, creatine levels are now 9. So clinically you are improving. But yeah, day by day when we do dialysis, twice a week or thrice a week, the levels will be decreased, and clinically and with the help of report we can advise the suggest the patient that you will feel better. So now Sheikh Saadi will talk about the adequacy of dialysis. What is the formula? How we calculate the adequacy of dialysis with the level, with the formula, like we all know, maybe KT by V. Okay, Saadi.
Thank you. It has been a fantastic talk with Dr. Yasir about the symptoms of uremia. So, coming to the part when why it was necessary to evaluate the signs for the adequacy of dialysis, because uremia is one of the most concerning factor that is required to judge the dialysis adequacy of the dialysis. So, as I have talked about you when I was talking about the definition, so adequate dialysis is the amount of dialysis, amount of dose of dialysis that you are giving to a patient, which can remove all these symptoms that Dr. Azur has just suggested. That patient may have nausea, may have vomiting, tiredness, fatigue, encephalopathy, of course. So these are some of the factors that will be released when the patient's uremia is corrected. All right. So what we need to focus is, of course, we will be judging the uremia scientifically, clinically with some formulas as well. There are symptoms. There are a lot of symptoms that will be corrected when the uremia of the patient is corrected, and when the uremia is corrected, that means the patient is getting
Replied that URR also is a factor.
exactly. That is very nice. We'll be coming to the
Furkan.
URR definitely. we'll be coming to the URR. We'll discuss more about KT by V and how URR and KT by V are linked to each other, and how KT by V is derived from the URR's formula. So coming back to my point, what I was making about is key symptoms. So symptoms are also one of the factors that is required to judge if the patient is getting adequate dialysis or not. Once the patient is getting adequate dialysis, those symptoms mentioned by Dr. Yasir, nausea, vomiting, encephalopathy will be corrected. Now, first of all, before jumping to the URR and KT by V, I would like to tell you about, wait. So I would like to tell you about the urea. So as Dr. Yasir has said, the uremia is the amount of urea, increased amount of urea. So we have, can you tell me, technicians, please write in the comment box, what is the normal range of creatinine in females? What is the normal range of creatinine in females? Why I am asking females, it has a reason. So please comment in the comment box, see what is the normal range of creatinine in female. And the normal range of urea is you will be finding different in different literatures. So basically it is around 10 to 50 milligram per deciliters. All right. So urea is normal is 10 to 50 milligram per deciliter. When it is increased beyond that level, the symptoms of uremia is being developed in the patient. And the symptoms that has mentioned, that losing body weight, patient will complain that I'm not feeling fullness of, he will not be feeling, what to say, always be hungry all the time, right? Appetite, loss of appetite, basically. Yeah, right. So loss of appetite would be there when there is a sign of uremia. So in such situations, how will be determining the determining that patient is getting adequate dialysis or not? So coming to that part, firstly we need to know what is urea, why urea is important, and how it looks like. So I'm coming to the whiteboard. You people can see behind me, there is a whiteboard. So I'm talking about urea. Urea. Why urea is dangerous? Urea. Why urea is dangerous? Why I want to talk about urea, and what is its importance? Actually, urea is a nitrogenous compound. When we learn about the definition, when we learn about definition of dialysis, what is dialysis? So we say dialysis is a process of removing nitrogenous waste. You're getting my point? So nitrogenous waste. So urea is a nitrogenous waste that contains molecules of nitrogen in it. That would be that is dangerous to the body, and this is how, which is causing these symptoms that has been mentioned earlier in the first part of the session. So now the symptoms. One of the important point now I am making. Listen, please. These symptoms that Dr. Yasir has mentioned, except for the encephalopathy, like nausea, vomiting, tiredness, fatigue, breathlessness, these can be the signs of anemia. All right. So if you people are well aware about that, patients on dialysis are having uremia as well as anemia as well. And their hemoglobin level is under range, is very low. So these symptoms should not be confused with symptoms of anemia. All right. So sometimes when you giving the proper ESA therapy, erythropoietin stimulating agent therapy, like you are giving erythropoietin, darbepoetin, sera, whatever kind of erythropoietin you are giving. So in those situations, these symptoms are also corrected. So at that time, it would be confusing that patient is getting good dialysis or not. You're getting my point. If you are giving erythropoietin, so these symptoms can be corrected. So these symptoms should not be confused with the correction of anemia. So once the anemia is corrected, but there may be a chance the patient is under dialyzed. If patient is not showing these symptoms, that doesn't mean he is getting proper dialysis. So what are the scientific ways now? What are the more correct way to determine if patient is getting proper dialysis, adequate dialysis or not? So there are two ways. Please write in the comment box, or whatever copy or notebook you are carrying with you. Note down. The first one is URR, and the second one is KT by V. These are the more accurate method to determine if the patient is having the symptoms of uremia or not, if he's getting good dialysis or not, if he's getting adequate dose of dialysis or not. So I have with me Mr. Deepak Sharma with us. He'll be telling more in details about the URR now, only URR. So Deepak, please.
So, hello everyone. So, as Saadi sir has mentioned a lot about, uh, dialysis adequacy. So, I'll be continuing after this. I'll be talk about URR. I think you all must know about what is URR, and URR, what URR defines. Basically, URR defines urea. You all know very well. So whenever we check urea, we say that we have done a good dialysis or bad dialysis. Totally depends on urea clearance. So when URR comes in the picture, why we check URR? Basically, whenever a patient comes to us, he or she has a doubt, like how much urea is reduced, how much good dialysis that patient has received. So in that scenario, they ask to technician or DMO, dialysis medical officer, duty doctor. They ask like, sir, we have this much elevated urea, so my dialysis was not done as it was expected. So there are chances, so many patients comes to us. So basically we have a idea, so that with by which we can tell patient, like, you can check your URR, so that you will have a good idea about your adequate dialysis, you have received a good dialysis or not. So this is called as URR. We can go with the KT by V also, but when it comes to the patient satisfaction, we have only URR. So we'll ask the patient, you give us a sample, pre-dialysis sample, and you go for a post-dialysis sample also. By comparing the values of both samples, urea, so we'll get a ratio, how much urea is reduced after the dialysis. You all know very well, urea's molecular weight is very low. It is only 60 Dalton. So it removes easily. But sometimes we use similar dialyzer or same dialyzer for all the patients we have. Like, we have a patient with 60 kg weight, and we have a patient with 120 or more than that. So we use the same or similar dialyzer. So there is there is a chance of less adequate dialysis. So, and again we will come back to URR. So basically, the right way of checking URR is like, first of all, you must take a sample pre-dialysis, as you all do, I know. And after second sample, post dialysis sample should be taken out just after the dialysis, within 5 minutes of the dialysis. When you have terminated the patient, just after the termination, within the 5 minutes, you should take a blood sample. Sometimes patient comes to us, they say, like, you have not done a good dialysis, I will complain to the manager or management or higher authorities, I will complain, you have not done the good dialysis. So there is a reason behind this. Patient is not wrong at their place. There is a there is a lack in their knowledge. You can tell them, sir, you should identify actually at what time the patient has withdrawn his or her sample, or he has given his sample to laboratory. They must have given their sample after 4 or 5 hours of the dialysis, or maybe after 1 hour of the dialysis. And what happens in between that duration after dialysis, that there is a huge gap. in between end of the dialysis and sampling. There is a huge gap. So what happens there? There is a mechanism. There is a principle works in our body and in dialysis also, that is called as diffusion. Whenever we take sample of the patient after 4 hours of dialysis, the diffusion starts working after the dialysis only. After 30 minutes of the dialysis, diffusion starts working, and the urea we have removed from intravascular space, again it comes from extracellular or intracellular space to it gets diffused into our intravascular space, so that when the urea transferred from intracellular or intravascular extracellular space to our intravascular space, it becomes more it will come in the blood sample, it will increase in the blood sample also. So whenever you check your the patient sample, it will come it will show that the dialysis is not adequate, you have not done a good dialysis. So it's like that. So the post sample should be taken out just after 5 minutes of the dialysis. It will give a exact result, it will give a exact value of the urea that you have removed. So there will not be any confusion in patient's mind also, and you will not also confuse, and you can tell the patient also, like, sir, you have given your sample after 4 hours of the dialysis or 3 hours of the dialysis, so that the value is raised. Sample that you have given, it is showing inadequate dialysis just because you have delayed the sample. So after this, I'll over to Mr. Sanjay. He will tell about dialysis adequacy more to you. Okay, over to Sanjay.
Hello guys, so as Mr. Deepak and Saadi sir told you about the education of dialysis and you guys have learned a more. So if anyone is here who know the formula of URR, if anyone know, he can type in the comment box. Then we will discuss about the formula. What is the formula of URR? So guys, you can write the formula in the comment box. We will check, then we will discuss on the formula. Okay, so actually the formula says that whenever you have to check the adequacy of dialysis by URR, you have to take the values in the formula like pre-urea minus post-urea upon pre-urea into 100. So whenever you are taking the sample pre-dialysis, you have to note the urea level and put in the formula. We will अपने इसमें कर दो formula लिख दो. Okay, so
Coming to the part of formula that we are discussing over here.
You can size both the things. First, URR and then click.
So what is URR? URR is urea reduction ratio. How is that?
थोड़ा सा पास है.
इससे करो इससे करना पड़ेगा
एक पकड़ लो. So let us discuss what is URR. URR is urea reduction ratio. That means the amount of So URR is urea reduction ratio. That means the amount of urea which is reduced during a dialysis session. Okay. So the formula is very simple formula, nothing very complicated mathematics. We'll give you an example of how to calculate URR also. So the formula over here is you can see the pre-urea. Patient is coming before the dialysis and you have taken a sample, and at that time before initiating the dialysis, the amount of urea in the blood it is having. So So that is pre-urea. Post-urea is the amount of urea post-dialysis after 4 hours of dialysis. The amount of urea you have sent the blood sample as Deepak has suggested. How to take the sample, how to send the sample, and again the divided by pre-urea 200. Let us understand this better with an example. So let's say patient Mr. Prabhakar. Mr. Prabhakar is a maintenance hemodialysis patient. He's on MHD and he comes twice weekly, all right, for dialysis. And on the day the doctor has asked one of the technician to get his URR done. He want to analyze the adequacy of the dialysis, amount of dialysis the Mr. Prabhakar is getting. So the one of the technician is taking sample and sending to the lab. The result come out to be the pre-urea of the patient is like 200 milligram per deciliter. It is 4 times higher than the upper limit of normal range. All right. So after the 4 hours of dialysis, his post-urea comes out to be after. It is very simple and logical that after 4 hours of dialysis, the urea will be reduced. Now we need to judge how much urea is reduced. Now his sample comes out to be post-urea is around let's say 80 milligram per deciliter. Now we will put the values in the formula. All right. Pre-urea is how much? It is 200 minus post-urea is how much? It is 80 divided by pre-urea. It is 200 into 100. So we will cancel 2 zeros with 2 zeros. 200 minus 80 is 120. 120 divided by 2. So it comes out to be 60. Remember, it is measured in percentage. Okay, see here, it is in percentage. Now, the Mr. Prabhakar's urea reduction ratio is 60% only. Now, what is the normal range? Normal range of urea reduction ratio is, some literature suggests that people who are getting 60% of URR will have lesser chance to get hospitalized. Some literature suggests that the URR value should be, the optimal URR value should be 65%. As DCDC as an organization, we follow that the patient's URR should be 65% at least. Alright, so 65% is the optimal value of urea reduction ratio. Now, how the value, let's say if the patient is having 65%, the other patient is having 70%, the more the value of URR, that means we are giving a patient a good dialysis. If the patient is having 70% of URR, that is we are giving good dialysis. If we are giving 80, if the URR comes out to be 80%, then it means we are giving a good dialysis. So 65 is the minimum value. More than that will be more sufficient, more good. All right. So the first factor is urea reduction ratio. Now we'll come to the second part. You can ask your questions, you can ask your queries in comment box. After finishing the session, we will reply to them. Now the second part is KT by V. KT by V is so Sanjay will be taking care of KT by V. He'll be telling you what KT by V. Thoda bada.
Okay, guys. So now we will discuss about KT by V. So if anyone has known that what the KT by V normal value should be, you can answer in the comment box.
All right.
If anyone know the answer that what KT by V should be for adequate dialysis, he can answer in the comment box. Okay, so now we will take a look that what the KTIV formula actually tells us. हमें क्या बताता है? It is the mathematical measurement of the URR actually. If we will put some values in the machine, so we can know that the dialysis being performed is adequate or non-adequate. In the URR case, you have to take a pre-blood sample and post-blood sample. Then you can check the specific dialysis adequacy has been achieved or not. But by using the KTIV formula, you have to put some values only in the machine. Then you can check that the dialysis is being adequate or not. So let's have a look what the KDI formula tells us. You have to make some values there. What is K? Anybody can, if anybody know about the K, he can answer in the comment box. What is the K in KDI formula? Okay. So I have 2 questions for you. If anybody know about the normal value of KDI, he can answer in the comment box. And what is the K in the KDI formula? You guys can answer in the comment box. If anybody has know about it.
comment कर दो.
Okay, so K is dialytic clearance for urea. In the formula, the K basically know is the dialytic clearance of urea. K dialytic clearance of urea. Now, in the specific dialyzers, or the dialyzer label, there is already mentioned that if dialyzer will remove urea from a such amount of blood, like if we say we have a dialyzer of 1.2 meter square surface area. Now we have a dialyzer which basically we use. He is 1.2 meter square. If K value is 196, it means that this dialyzer will remove urea 100% from 196 ml blood per minute. Okay. So now let's have a formula.
And your blood pump is running at 200.
Yeah. This is at QV. What is QV?
Guys, please comment what is QB and QD.
Okay, so now if you are getting that one dialyzer of 1.2 meter square surface area have 196 dialytic clearance of urea at the blood flow rate of 250 and dialysis flow rate of 500. So we have to put the values. 196. What is the T? What do you mean about T? T is the time, dialysis time. What the time you are giving to the patient, it is known as T. So basically, in general, we count the time in the hours. Like we have taken a patient for 3-hour dialysis, 3.5-hour dialysis, or 4-hour dialysis. But we have to put the value here in the minutes. So we know that there are 60 minutes in 1 hour. So if we are taking a patient on 4-hour dialysis, that will be equal to 240 minutes. Okay. Now we have to calculate this. Okay, now we have to check about the V. Anybody know what is V in the KDIV formula?
V, I think, Sanjay, I think V is volume of blood. Is it right or not?
Okay, what are you saying, Deepak?
I think V, you are asking now what is V?
Yeah, what is V in the KDIV formula?
V, I think V is the volume of blood the patient is having. The patient is carrying the volume of blood. I think this is called as volume. Am I right or wrong?
No, you are not right, Mr. Deepak.
So, can you please tell me the right answer? Can you please tell me the right answer?
Exactly.
Or please, guys, put in the comment box what is the right answer of V in KT by V.
Yeah, so many people think like V is the volume of blood.
Yeah, right.
Yeah, many people think that V is the volume of blood in dialysis, as Deepak has told us, but actually V is the volume distribution of urea. What is it? Volume distribution of urea. So actually, as we know that urea is a very smaller molecule, have 66 Dalton of molecular weight. So we assume that volume of urea is distributed in whole body where the water is exist. So we know that there are 60% of water in our human body. Okay, so there will be 60% of body weight. What it will be? 60% of body weight. So now we have a 100 kg patient. Now we have a 100 kg patient. So what will be the volume distribution of urea? Deepak? We have a patient of 100 kg.
It will be 60.
60. Exactly.
Yeah.
Because the V, yani the volume distribution of urea is the 60% of patient body weight. So our V, we have get answer. Volume distribution of urea is 60%.
Okay,
So
now I got the answer. The volume of that you were asking, what is V in KT by V? So now I got to know that it is volume of urea that is dissolved in the water of a human body. Thank you, Sanjay.
Yeah,
Please
right.
carry on.
So now we have to check it. We have calculated the 196 into 220. Okay. There is 4704 This is ml per minute. Okay. We have to convert it into liters. How will we convert it in liters?
We have to divide this with by 1000.
1000. Okay. Last we can cut to this. This is nearly very expected. So we can cut whole 3 dots from this. We have got the value of KT is equal to 47.
7.
Okay. Now we have to put the value of V. Okay. What is the value of V? This 60. The 60% of patient body weight.
Okay.
It will be 60. So anyone can calculate 47 divided by 60. What the answer will be?
Calculation. So, Sanjay, Mr.
So if you guys can calculate, can answer in the comment box.
Mr. Shaikh Saadi is calculating for us.
Okay.
So
0.78.
it is 4.78. So
0.78. So Deepak,
yeah.
we got a value of 0.78 of KTYV. So is this dialysis adequate or not?
I think the dialysis is not adequate. As you
Not
said,
adequate.
the dialysis you should achieve the KT by V at a good level. I don't know the good level. What is good level? But I think it is not no good dialysis. 0.78 is too low.
It is too low.
So can you please tell me what is the correct range so that we can understand the dialysis has done is good or not?
Yeah, the smart people has commented the answer in the chat box. If you can chat.
Okay.
It is commented or not? The exact value of KTYV. Okay. So KTYV should be achieved at least 1.2 to 1.4 for standard dialysis. For standard 4-hour dialysis. What is the normal level of KTYV?
1.2 to 1.4.
4.
Okay, I got it right
Exactly.
now.
So at least 1.2 KTIV should be achieved. Then we can consider it as a adequate dialysis. Otherwise, it is not adequate dialysis. What is our value? 0.78.
Okay, Sanjay, you mean
Yes.
when we receive minimum 1.2 of KT by V, that means the dialysis is adequate. Am I right?
Exactly.
Okay, so here we got the value 0.78. That means the dialysis was not good.
Not good.
Okay, thank you so much, Sanjay. Please carry
So
on.
guys, now I have a question for you. What is the reason that we have put all the values, but we got only 0.78 KTIV? Why it is too low? What should we change to achieve an adequate dialysis in this scenario?
Okay, you are asking what are the possible reasons
Yeah.
for this low value.
Exactly.
This is the value we got after the dialysis, after 4 hours of the dialysis. So what are the possible reasons? Guys, can you please tell us in comment box what may be the possible reasons for this, inadequate dialysis? Can you please tell us? I'm not getting the idea. Please tell me. So here in comment box, Furkan has written blood compartment, dialysate compartment, but Furkan then okay, volume. So okay, the volume, okay, volume of what?
Okay, no issue.
Okay,
What is the
Sanjay,
main-
please
yeah.
continue.
Next, we have to take a look that why the KDYV is too low in this scenario. We know that to achieve an optimum level of KDYV, to achieve an adequate dialysis, we have to take a standard urea clearance dialysis. Our patient body weight was 100, and we have used a 1.2 meter square surface area dialyzer, where dialyzer urea clearance was 196. So that is not comparing with the patient. If we are using, if we have 100 kg of patient, we have to use at least 1.8 meter square dialyzer. Okay, then we will achieve at least 250 dialyzer clearance of urea.
Okay, okay. Now
So
I got
to
it.
achieve the adequate dialysis, the K value should be high. Okay. Now where the K depends, because how
K-
to increase the value of K?
K is clearance of the dialyzer. How much a dialyzer can clear the urea?
Okay. So how can you increase the value of K?
Value of K.
K.
Okay, please guys put in comment box what will be the value of K.
So we know that the K is the dialyzer clearance of urea. We know that we have a dialyzer of 1.2 meter square. It has 196 dialytic clearance of urea at the blood flow rate of 250 and dialysis rate of 500. Now, if we increase blood flow rate or dialysis flow rate, the K value, the clearance value will be increased. So, if we kept it 300, 350 or 700, the K value should be approximate 220.
Okay, Sanjay. So you mean if we increase the blood flow rate, it will increase the clearance of urea?
Clearance of urea.
Okay, this is so really good.
Yeah,
That's so
now
nice.
We also know. Now you also know that we can increase the blood flow rate or dialysis rate for a specific range only. If we have a patient of 100 kg, we also have to increase the surface area of the dialyzer. If we increase the surface area of dialyzer, the K value is also increased at the blood flow rate of 250 and dialysis rate of 250. So if we think,
Okay, so Sanjay, now I got to know that once I dialyzed a patient whose body weight was 110 kg, and I dialyzed him on the dialyzer of 1.2 meter square of dialysis, space, surface area. And after the dialysis, what the value we got as URR, that was only 40%. So I got to know now, as you told us that the surface area should be increased as per the patient's body weight. That dialyzer should be selected as per the patient's body weight. So this, I think, this is the right way of doing the dialysis, correct dialysis, adequate dialysis. Thank you so much. Please carry on.
so as per the patient body weight, you have to use a suitable dialyzer with optimum level of dialyzer surface area according to patient body weight. So now, if you will increase the surface area, if you will increase the blood flow rate, or if you will increase the dialysis flow rate. The K value or dialyzer clearance of urea will be automatically increased. Okay, so we have to increase the value of K. We can increase the value of K by using a higher surface area dialyzer, increasing blood flow rate, or increasing dialysis flow rate. That is the one point. Second, we can also achieve the optimum level of dialysis adequacy by increasing the dialysis time. Okay, so if we are taking a patient on 4-hour dialysis, there will be 240 minutes. So many times what happens that people take the patient for 3 hours, 2.5 hours only. So the value of T is already received.
Maybe the patient is not feeling well. We do the dialysis within 2.5 hours.
Exactly.
And after that, patient complains that I am not getting the good dialysis.
Yeah.
So these are the reasons.
Yeah, those are the reasons. So in any case, if the dialysis time will be reduced, the KDIV will be
that
reduced.
Will also affect the KDIV.
So you have to take the all 4-hour dialysis for a patient to achieve an adequate dialysis therapy. Now, the value of V. Now, if we increase the K, the KDIV will increase. If we increase the time, the KDIV will be increased. But the V is the volume distribution of urea, which is directly connected with the patient body weight. So, if the patient body weight will be increased or volume distribution of urea will be increased, the KDIV will decrease. They are opposite to the answer. Okay. So now you have a patient of 100 kg and you have a patient of 70 kg and you are using the same dialyzer at the same blood flow rate and the same dialysis flow rate. So the KDIV value will be different for all those patients. Okay. So you have to take the minimum volume distribution of urea to achieve the adequate dialysis. So we know that how much fluid will be increased, how much blood fluid will be increased, the volume distribution of urea will be increased. So you have a patient who is have the fluid overload of 4 liters. So the V value is increased, and when the V value is increased, the volume distribution of urea will be increased. So we have to use the minimum fluid overload of the patient, so you can achieve the adequate dialysis and the optimal level of KDIV. So guys, that is the mathematical calculation that what the parameters affect the adequacy of dialysis, how you can calculate it, and how you can get an adequate dialysis for the patient. So guys, you have to take a oath that whenever you are dialyzing a patient, you have to achieve the KDIV at least 1.2. If it is less than 1.2, that means it is not beneficial for the patient. So please check at your centers, at your patients. You have to achieve 1.2 KDIV at any rate. If multiple time patients are getting KDIV below 1.2, it will affect the patient survival. If you will check in the long term, that their survival rate will be decreased and major different type of complication will be very there.
So, Sanjay, as per your explanation about the KT by V, like I'm getting this, there should be a level of 1.2 KT by V for getting a good dialysis, and it should be more than that.
Yeah, actually there are a specific range 1.2 to 1.4.
Okay, so like if the level is 1.2 to 1.4, so that means we are giving a good dialysis to the patients. And now in all our machines, like we can say in Fresenius, in Nipro, we have these options. So we can fill the data in Fresenius, we can fill the OCM data, and after the dialysis, the machine will give us a data of our KT by V.
Exactly, we have to put only some values as per the patient. Then after the dialysis, you will get a calculated amount of KT by V.
So it is important to achieve a KT by V, like to maintain a record of KT by V for all the patients.
Very, very important.
Okay.
Because it totally depends the patient's survival. Okay. If you have to track a patient lifestyle, that you have to check that how many dialysis he had get adequate and how many dialysis he got inadequate. Okay. So for the study purpose, for the data purpose, you have also record the KDRE value at every dialysis. So Sanjay,
I have seen many technicians saying, "Sir, in URR, in KT by V, we check potassium, sodium also. Not only urea, we check sodium, potassium also in KT by V. So, is it correct or not?"
So Deepak, as we also know that we have taken the value of K only. K is the dialyzer clearance of urea. So
Okay.
if people say that the fluid or potassium or other electrolyte, that can be a marker to check the adequacy, but in the KTIV formula only clearance of urea we check to check the dialysis adequacy. Only urea we use. Okay.
Okay. Now I want to call Sheikh Saadi. So Sheikh Saadi, I want to know like what are the factors? What are the factors which really affect the which affects the adequacy of, which can affect the value of efficacy of the dialysis? What are the factors that are involved in increasing the levels of KTYV?
Alright, so very good question that doctor has asked. Yesterday one of our colleagues from some center, he was also asking about the potassium-free dialysis. Does it impact the overall adequacy of dialysis? Or what are the key features that a technician can follow? The tips and tricks you were talking about. How can it be helpful in maintaining the good adequate level of hemodialysis? So as Sanjay suggested that the value of K ultimately, we say na, when we used to ask in the interviews the questions about how can you increase the KTYV value technically, how can you increase the clearance of how can you increase the clearance of a patient technically? So it depends, the K value depends on QB ultimately. So when the QB is higher, the value of K will be higher, so that KTB overall will be higher. So we need to put these factors bigger, K and T, and B should be smaller as Sanjay suggested. Now coming to the part, what are the factors that are involved that affects the adequacy of dialysis? So
how we can increase the adequacy?
Right. So I'm telling that the value of K, value of T, and value of VD, it is responsible for the value of overall KTYV. So coming to some few more things that I would like to mention is the rule of 6. Rule of 6 about AB fistula. It says the recirculation impact the adequacy of hemodialysis. What is recirculation? Basically, you can understand with this. Recirculation is the mixing of impure blood with the pure blood, or you can say the mixing of filtered blood with unfiltered blood is the recirculation. So in the rule of 6, we see that the distance between the arterial and venous needle should be more than 6 centimeter. Arterial and venous needle, the distance should be more than 6 centimeter, which will allow the recirculation to lesser down and clearance to be increased. Now, some things that you need to keep in mind while taking the blood samples while doing URR. So in the pre-samples, when you are taking sample for pre-testing, pre-urea, so you need to remember these few things, that the sample should not be diluted with saline, normal saline and heparin. No. Okay, so the sample should not be diluted either with saline, normal saline, or with heparin. It should not be diluted. Once you cannulated the patient with the AV fistula needle, take out the sample first, then start the dialysis, then give the heparin. Do not give heparin before taking the samples. All right. So these things you need to remember while carrying before sample, pre-sample. Now post sample. Post sample, as you are all are aware that the heparin should be discontinued before 1 hour of termination of dialysis. Like we are doing 4 hours dialysis, the heparin delivery will be stopped 1 hour prior to the termination of dialysis. Why we are doing? Because we do not want the sample to be diluted with heparin. All right. So in the post sample, when you are taking the post sample, you need to remember some few things. First of all, you need to slow down QB or blood flow rate for 100 ml per minute. Slow down. Okay, write down these things in your notebook. It will be asked in the questions of railway examination and medical colleges examination when you are giving the paramedical exam. The post sample, the blood flow should be decreased to 100 ml. The UF rate should be decreased or should be stopped. And these things are done for at least 30 seconds. Then stop the pump. Clamp the arterial side. Take out the post sample in the vial, in the plain vial, not red top vial, plain vial, yellow vial or red top vial. These are the plain vial. These are the plain vials, red top vial or yellow top vial. So you need to take the sample, stop the blood pump, take out the blood sample. As for example, the dialysis is for 4 hours. So you can take the sample on 3 hours and 59 minutes and few seconds, 30 seconds before. At this time you can take the sample, and after that, when you have taken the sample, with doing these things, slow down the blood flow rate and UF rate should be stopped. Take out the sample and then start again for dialysis and terminate when the time is over. So you need to remember, in the pre-sample and in the post-sample, the sample should not be diluted with saline or heparin. This is the point I was trying to make, and I hope this session has been very helpful in creating awareness about adequacy of dialysis, and I hope the patient will be getting a good dialysis from the technicians who have joined in this session. So one of the questions that was asked, I would like to discuss with Mr. Deepak with me. But Furkan has asked that does TDS impact the adequacy of dialysis? What do you say?
Yeah, definitely. TDS impacts the adequacy of dialysis. What I understand, TDS impacts. Yeah, TDS will decrease the adequacy of dialysis as per my understanding. Can you please explain?
TDMS. No, it is TDS. What? Furkan, have you asked the TDS or what? TDMS.
TDMS is nothing. Is just a data collecting method.
When we are talking about adequacy of dialysis, so we have two parameters. It can impact overall health of the patient. Like if the TDS is higher, then it may have the problem with particular contaminant. Like for example, if the aluminium is high, the patient will have TDS. If the aluminium is high, then patient may have aluminium related encephalopathy, dialysis dementia, these kind of things patient can have, or other things like particular. So it is the point about TDS, when the particular contaminant is coming in the water, it may cause that particular specific situation to the health of the patient. But I do not think that it may affect, because when we see in the formula KT/V, so there may be a chance it may affect the rate of diffusion. The TDS may affect the rate of diffusion, but overall it has a very negligible impact.
Okay. Mr. Saadi, can we call it back filtration also?
Back filtration of?
Back filtration of something is coming higher in our RO water. So it is.
Let's say, because Deepak, what I see is urea. Like when we have urea in our blood, it is very high in the blood, and in the dialysate side it is 0, right? And we are talking, when we consider when we say about the factor, so we consider URR and KT/V. That calculates urea only. So I'm trying to make a point, when we are particularly seeing URR and KT/V, the TDS must not have effect on the URR calculations, but rather it has effect on the rate of diffusion or particular contaminant that is coming in the blood that may cause, like for example, zinc may cause hemolytic anemia, chloramines may cause hemolytic anemia. So, briefly, lastly, just note down in very few seconds. We are closing the session. We are going to be end this live session. We are giving you the tricks. Write down. Get ready your pens. The 4 tricks. Write down. First one, increase the blood flow rate. Increase blood flow rate. 200 चल रहा है किसी का 300 बढ़ा दो. ठीक है, लेकिन see one very important thing. You need to care the cardiac efficiency. If the patient's heart status is all right, ejection fraction is all right, if the patient's heart is supporting, then only go for the higher blood flow rate. Until you do not know about the cardiac efficiency, cardiac health, do not go for the higher blood flow rate. Ask the clinical team, ask your doctors there, can we go for the higher side blood flow rate. Second one, dialysate flow rate. Why dialysate flow rate? So we know about the ratio. 1:2. When the blood flow rate is higher, like for example, we are doing 250 ml per minute, so dialysis should be 500 ml. When we are doing 400 ml per minute, the blood flow is 400, then the dialysate should be 800 ml. So the amount of blood flow is increased, dialysate flow should be increased, and the diffusion will be increased, rate of diffusion increased, and when the rate of the diffusion is increased, the clearance will be increased. Third factor is time, but time is, time is very like when it is asked to do. Like when we are giving 4 hours dialysis, but your doctor is suggesting you just go for 1 hour or more, 1 hour of more dialysis. Only in that situation you can do one more 5-hour dialysis until you are not asked to do. But time is an important factor. So do one thing, just go for 4 hours complete dialysis. Each and every minute is important. Last hour is very important in removing the urea and creatinine. All right. So each and every minute is very important to utilize the all 4 hours for the dialysis. Fourth one, write down, very important, rule of 6 we have learned. The recirculation rate should be very less. The recirculation rate should be very less. For that we need to follow distance between arterial and venous needle 6 centimeters. All right. So winding up.
Frequency of dialysis.
So frequency of dialysis as suggested by the nephrologist, it should be thrice weekly. But those patients who are getting twice weekly should be counseled for thrice weekly dialysis, so that their dialysis adequacy can be increased, their overall health impact, the symptoms of uremia can be corrected. So that's all from my side. Going back to Deepak Sharma for the latest updates.
Thank you so much, Saadi, for the informative, session on adequacy. I would like to add one more thing. What I have observed during my, experience in dialysis department. So I have seen a lot of patients with the catheter and who are receiving dialysis, and AV fistula patients were having more, adequate dialysis. They were achieving 1.4 kTIV, and some of them, with catheter were not achieving that, that type of quality of dialysis. They were not achieving. So I believe we all must encourage our patients to shift on fistula, AV fistula, and whenever they have catheter, the patients having catheter, there are a lot of problems. Red side, arterial side is not working, venous side is only working. So we are doing dialysis on that particular basis only. We are taking out the blood from venous side and returning from arterial side. So it basically it decreases the efficiency of dialysis and adequacy of the dialysis. There is a maximum chance. There are maximum chances of recirculation. So please make your patients aware about the pros and cons of catheters. Ask them to shift on AV fistula as soon as possible, so it will increase their dialysis adequacy. They will receive, it will increase their life expectancy also. So thank you so much for the joining. Thank you so much for joining with us. So now we will be showing you our team for the final goodbye with you guys. So thank you so much for joining with us. So this is our team. Here is Sanjay, Dr. Yasir, and Sheikh Saadi, and this side me, Deepak Sharma. So thank you so much guys for joining. or next time we will come again with the multiple things, and again with a fresh session. Till then, thank you so much. Bye bye. Take care.